section is on somatoform disorders for behavioral science and psychiatry for Falcon Physician Reviews. What is a somatoform disorder? Somatoform disorders present as patients who have physical symptoms without any medical explanation. They are frequently impaired in their social and occupational functioning, and also sometimes look into getting some disability for their somatoform disorders. These symptoms are not consciously produced by these patients. Somatoform disorders include pain disorder, somatization disorder is also known as Burkitt's disorder, hypochondriasis, conversion disorder, and body dysmorphic disorder. Pain disorder is one of the first topics that we're going to talk about, and frequently you'll be asked to differentiate this between malingering on the USMLE. So these patients with pain disorder are plagued with chronic pain, and it's very constant. No medication will be helpful. Also, in the vignette, you will notice that the patient has been through multiple procedures. So they've had multiple radiographic examinations as well as surgeries, and there's no help with their pain. Usually, there's also a comorbid depression or dysthymia present with it as well. First of all, we need to make sure that there is no medical cause. So it is definitely true that you must rule out a medical cause, do the x-rays as needed, but these people go a little bit past that. They just even go on to further examinations. They go to multiple doctors to really see why they're having so much pain. And how do you treat this? Well, for most of the somatoform disorders, the best way to approach a patient is not to say, it's all in your head, you're making this up, the pain will go away on its own, because that only makes things worse. But to try to tease out some underlying stressful situations that the patient is having and help them see that sometimes our bodies respond to distress or depression through physical symptoms instead of being able to talk about them. And if you can engage them in some psychotherapy and help them deal with these problems, generally the pain disorders will decrease. Sometimes an antidepressant is helpful, such as an SSRI and the other antidepressants. Also, you can do some biofeedback. Sometimes nerve blocks are helpful, and even hypnosis. It's also very important that these patients see their primary care doctors on a regular basis, once a month, even if they're not having a new problem, just so that they can establish rapport and feel like someone is taking care of them. What is the definition of somatization disorder? This patient has to have multiple medical complaints, often pain, but not just pain, and it has to start before the age of 30. So you must have at least 4 pain symptoms, along with 2 gastrointestinal symptoms, 1 sexual symptom, and 1 pseudoneurological symptom. And in your notes, they'll give you a more detailed view of exactly what the 4 pain symptoms are, the gastrointestinal symptoms are, and the sexual and pseudoneurological symptoms are as well. Again, these patients don't necessarily have to present with all 8 symptoms at one time, but over the years they would have been worked up for multiple somatic complaints. Again, they would have had multiple procedures, surgeries to help correct them, and nothing is helping. Usually they seek disability because they really feel that they're ill. Frequently they're female. And we must remember that these patients are not faking these symptoms. They really do have these symptoms. So again, the approach would not be to tell them that they're making that up and it's fake. Again, it would be to help them see that sometimes stress can make people feel very depressed, and when we don't know how to express it in the proper ways, our body tells us that we're very stressed out. We must also remember that somatoform disorder or somatization disorder is not hypochondriasis. The differential between the two is that hypochondriasis is actually that you feel like you have a specific disease, whereas in somatization disorder, you just have multiple symptoms. For somatization disorder, how do you treat this? Again, you must see a primary care doctor, the same doctor, very frequently, once a month, once every couple of weeks, and help them make treatment decisions, help the patient find constructive ways of coping, make sure you're not overlooking any kind of medical diagnosis, and also try to explain to the patient that maybe these symptoms are psychologically derived. But never confronting the patient is a good idea. If you confront a patient, it only makes things worse. Next, we have hypochondriasis. And these patients believe that they have a specific disease. So maybe they wake up with a headache one morning and they say, oh my God, I know I have a brain tumor. They have to go see the doctor because they're convinced that they have a brain tumor. These symptoms must be present for at least 6 months, and it is frequently found in midlife, such as in your 30s and 40s. Again, it is predominantly in women. So you're going to look for a patient on your exam who has been evaluated for a very specific disorder, and they will have to put in the illness itself. So it has to be a disorder. It won't be just a symptom. They'll talk about, oh, I have a brain tumor, or oh, I have HIV, I have cancer of my stomach. So you're looking for a very, very specific illness. These patients are not delusional, so you want to differentiate them between schizophrenia with some somatic delusions or delusional disorder with somatic delusions as well. So you have to differentiate those patients. And how will you manage it? Again, brief scheduled visits every so often, and also some cognitive behavioral therapy and some individual therapy will also be very helpful. Conversion disorder is our next somatoform disorder, and it is the most common of the somatoform disorders. Again, more common in females. And what conversion disorder will be like is the presence of one or more neurological symptoms that are unexplained by a medical or neurological disorder. So, for example, someone will come in after they've had a very stressful situation happen to them, and they may be paralyzed. You'll run a head CT, an MRI, and there'll be no lesions in the brain. And at times, the patient will accidentally be able to move their limbs, and so the neurological team will get kind of suspicious that maybe these symptoms are psychological in origin. Frequently found in people who have histrionic and dependent personalities. Again, you do want to make sure that there is no neurological cause, so you do want to run the appropriate test. You don't want to just say, oh, this looks fake, this is not true, and because you might be missing an important medical diagnosis. And you want to rule out any other kinds of psychiatric illnesses such as schizophrenia, factitious disorder, anxiety disorders, malingering. If you're looking for malingering, you're looking for someone with secondary gain, so they want to get out of a court date or want to get out of going to prison. Those are the things you would look for to rule out malingering. So how will they present to you on the USMLE? Again, it'll be a patient who has an onset of a neurological impairment. So usually something like a stroke or a seizure. Seizures are very common. And actually a lot of patients who have conversion disorder with seizures actually have seizures in real life. So it's very easy for them to mimic these symptoms because they know exactly how it's like to have a seizure. So an example would be a teenage girl who was paralyzed from the waist down since she found out that her boyfriend was cheating on her. So if you were to interpret that, it means she wants to leave him, but she can't, so she paralyzes herself. Frequently when you ask these patients, are you concerned about your paralysis? Are you concerned about your seizures? They won't have very much of an expression. They won't be very bothered by it. They'll say, no, I'm not worried. I know the doctors are taking care of me. I'll be fine. And which is very different from someone who would suddenly have it because of a medical reason. So what they call that is actually la belle indifférence. So it means that they exhibit very little concern for their impairment. How do you manage a conversion disorder? You want to establish a trusting relationship and also help them establish coping skills in alternate ways. Again, for someone with conversion disorder, you will say, sometimes people get very stressed out and our bodies are telling us in different ways that we're stressed out. Do you think that can be happening to you? And a lot of times the patients will say, yeah, I agree. I think that I'm being very stressed out, but I just don't know how to cope with it. And eventually the symptoms will resolve. Our last somatoform disorder is body dysmorphic disorder, and on your slide you'll see a picture of Michael Jackson. And the reason why people think that Michael Jackson might have body dysmorphic disorder is, as you've seen through the years, his nose has progressively slimmed down and become more pointed throughout the years. So what a person with body dysmorphic disorder has is that they have a specific deficit of their body. It's not the complete body image, but it's a specific deficit in their body. So is it their nose, or they feel their lips are too small, or their ears are sticking out, but they'll give you a specific body part. And they're preoccupied with this, and they greatly exaggerate abnormalities in their appearance. It is frequently common in young women. You want to rule out any psychotic disorders, any other anxiety disorders, any personality disorders, obsessive-compulsive disorder. And how this will present to you on the exam is that it will frequently be a young woman who's going to go to the plastic surgeon and say, I need to get my nose done, or I need to get my ears pulled back, but it's usually going to present to multiple plastic surgeons asking to get a surgery revised over and over again. She will also be very obsessed, frequently looking at herself in the mirror, and will be very self-conscious about it. She'll stay at home, won't go out, and it will interfere with her functioning. And frequently, other people won't see the deficits that the patient is seeing. How do you treat this disorder? Cognitive behavioral therapy is helpful, and also giving them some reality testing have been shown to be somewhat helpful. And you can also try antidepressants because frequently these patients will also be very depressed. Next, we have factitious disorder and malingering. Now, these are not somatoform disorders, but are very closely related, and that's why they're added in this section. So how are these different from the somatoform disorders? Well, in factitious disorder and in malingering, these are consciously produced symptoms, whereas in somatoform disorders, they are unconsciously produced symptoms. And they're very willing, and they're very difficult for physicians to get their hands around because you know that your patient is consciously producing these symptoms, so you kind of feel like they are tricking you or they are manipulating you. So in a factitious disorder, the patient that you're going to see is a person who wants to assume the sick role. Again, it is conscious. And sometimes in children, factitious disorder can actually be done by proxy, where a mother will constantly bring in the child saying he has abdominal pain and his abdomen is distended and he needs surgery, and this child would have gone through multiple surgeries. Factitious disorder is also called Munchausen's disorder, and if you do it by proxy, then Munchausen's by proxy. So if you see it on your exam as either Munchausen's or factitious, it's the same thing. They're consciously produced symptoms to be in the sick role. What are the differential diagnoses of factitious disorder? You want to evaluate for someone with somatoform disorder, schizophrenia, substance abuse, antisocial or histrionic personality traits, and also want to make sure that there is no underlying disorder. So how do these guys usually present? Generally, it's usually someone who has been sick in the past and knows something about the healthcare industry, or it's someone who actually works in the healthcare industry. So frequently you'll get a vignette with a nurse in the hospital who comes in because her sugar keeps dropping, she becomes hypoglycemic, and they don't understand why. They've checked her C-peptide levels and her insulin levels, and they're absolutely normal. Why is this happening? And what it is because healthcare workers have access to medical supplies. They can induce the symptoms into themselves. So you want to watch for somebody with recurrent, unexplainable symptoms, even though they're being closely observed. I have an example of a patient that I saw who actually drove himself from Louisiana to Texas because he said that no hospital in Louisiana could help him for his condition. He said he drove all the way 3 hours to Dallas because he had a temperature of 105 and he had multiple skin abscesses and needed help, but no one in Louisiana could take it. But once he got to the hospital, his temperature was never above normal, and the nurses couldn't find any abnormalities. The doctor couldn't find any abnormalities of why this patient was getting these abscesses. They ran multiple tests and multiple immunological studies, and he was completely fine. And intermittently, the patient would tell the doctors, I checked my temperature this morning and it was 104, and the nurses would come right back and check it right behind him, and it would be completely normal. This patient also had a long history of multiple abdominal surgeries, maybe 12 to 13 abdominal surgeries since he was a child, multiple hospital admissions, and we were also able to tease out that he had actually asked to leave from multiple hospitals because they thought he was feigning his symptoms. So this is a person who wants to be sick and wants to get attention through being sick. Treatment is usually very difficult. It's difficult because patients often terminate the treatment relationships when they're confronted with a diagnosis. They move from different hospitals to clinics just so they can satisfy their need to be sick. So how do you treat these patients? Again, do not confront them. Do not tell them that you're really not sick. You're just making up these symptoms. You need to choose a non-judgmental approach and recognize that the patient is really suffering from a disorder, which might actually be mental rather than physical, and that actually may help. Next, you'll have malingering. And again, malingering, like factitious disorder, is also consciously produced. And it's different from factitious disorder in that the gain, I guess you could say, in factitious disorder is to be in the sick role. Whereas in malingering, there's an actual concrete gain, such as getting out of prison, not having to pay child support, getting some money. So these people are actually faking their symptoms to get out of something. It is not considered a mental illness. And again, you want to rule out that it's not a somatoform disorder. You want to rule out that there really is not a medical cause. But how will you be able to recognize these people on your exam? Most likely it'll be a man. Most likely it'll be a man who's been to prison before, so someone with some kind of antisocial traits. Also, these patients will not follow through with the doctor's recommendations. So if you tell them to take this medication and come back in a week and we'll see how your pain is doing, these patients will not do that. Also, as in pain disorder and somatization disorder, these patients will not go through the rigorous testing, the different surgical procedures. They will refuse to do that. They will refuse any of the recommendations by the doctors, and they will seek disability for them. Now, we also mentioned that pain disorder and somatization disorders will also seek disability, but they will have gone through all the recommendations made by the doctors. They will have gone through all the rigorous testing. So that's how you're going to see a major difference between pain disorder and malingering. So how do you treat someone with malingering? Again, it's better not to confront the patient because he won't be able to trust you, and he'll just actually go to another doctor and go and get more help. So that's not very helpful. But mention to the patient, you know, I have looked at all your medical evaluations and I really can't find anything that would be causing you this much pain. And try to see if the patient will actually then be able to tell you why he's having these symptoms. Again, thoroughly document your interactions with these patients because sometimes they can be very rude and irritable. This concludes our section on somatoform disorders for behavioral science and psychiatry for Falcon Physician Review. This concludes our section on somatoform disorders for behavioral science and psychiatry for Falcon Physician Review.